But in each particular case, it requires an important discussion with your healthcare provider to get to a treatment regimen that you're comfortable with.
So, what are the initial steps someone with a history of cardiovascular issues should take towards adopting a plant-based diet?
Well, I don't think they're any different from anyone else, right? Which is, most human beings are wired in an all or nothing type of fashion. And so for the vast majority of people, I tell them to go home and clean out their fridge, freezer, and pantry and start over. And I give them a whole bunch of resources about how to do this. As you may know, the Physicians Committee for Responsible Medicine, amongst many other groups, have starter kits and cookbooks and how-tos and all these lovely things. And it's important for people to become knowledgeable and make it happen. Sometimes people want to know like an example of what I eat for a day or, what other people might eat for a day. And I try to really give them some concrete examples so they can go and start doing these things every day. But I'm not sure there's a magic, way of getting started. Change is hard. And when you grow up like I did in New York, eating terrible foods, making a drastic change can be challenging. But getting the appropriate help that you need from a registered dietitian or even a chef, a physician that's helpful and knowledgeable in this space, all super useful.
Thank you. So, in your research, what has been the most striking evidence supporting plant-based nutrition for cardiovascular nutrition or part cardiovascular prevention?
I think that there's an enormous body of literature that's published every year that continues to show evidence in favor of this approach. Now, some of these are difficult to fully sort out, but I think there's more than enough signal in some of the noise and some of the randomized controlled trials that have been done over the years, including the Leon Heart Study, the Lifestyle Heart Trial, which was Ornish's, the Mount Abu Heart Trial in India, the pro-vegetarian cohort of Predimed, which was the Mediterranean diet study with the vegetarian people that were following a vegetarian Mediterranean diet, and many, many others. So I would say that the evidence is quite clear, so much so that every single professional society on the planet endorses a plant-forward diet.
So, as I'm sure you're well aware, Dean Ornish was able to show that you could reverse heart disease on a plant-based diet. Dr. Esselstyn was able to show the same. Is there any other diet or lifestyle intervention that has been able to show a reversal of cardiovascular disease?
Yeah, so reversal is a little bit of a loaded term, and it's all about what it's defined as. So what I usually tell people is coronary disease is a systematic and progressive disease. And when you implement drastic lifestyle changes, it typically halts the disease. If you're very lucky and your disease is very early and you don't necessarily have calcific coronary disease, you may be able to reduce some of the plaque, but not everybody can do that. So a lot of people who have come to see me, have very, very, very advanced heart disease needing urgent intervention. They feel terrible. They have angina and chest pain at rest. Eating peas and carrots at that point may help, but it may not cure the disease at that point. So what I always tell people is your mileage may vary when it comes to reversal, but the goal is to live your life without this sludge in your pipe getting worse. The analogy I typically use is that if you were to look at your house, let's say it's 40 years old, chances are if you were to look at all the pipes, there'd be sludge and hair and soap scum and all these nasty things, but everything is flowing, or you would have called the plumber. And so if you're 70 or 80 or 90 or 100 years old, you may have some sludge in the pipes, but everything's working and hopefully it won't ever get worse. And that's a powerful approach. So I use the term reversal pretty carefully because it is not a guarantee, but the goal is really to prevent progression of the disease or halt it altogether.
So, with regard to Dr. Esselstyn, there's a very famous picture of I believe it's the Widowmaker that was clogged, or I don't know the exact terminology, and then was open at the end. What went on there? What's an explanation of that?
Someone was quite lucky. I mean, again, if you find disease early enough, you can show reversal. But I would say that, yes, that is a beautiful picture that he showed. Essie is a good friend of mine. Ornish is a good friend of mine. We've worked together on a variety of projects over the years. And there are people out there who are lucky enough to have that. I just don't know how many people and which people those are. So I would hate for somebody to put all their quote unquote eggs or vegan eggs in a basket and hope that they're just going to do just fine. Remember that in coronary interventions, when I was growing up in cardiology, right, we first put in these full metal jackets, right? We stented anything that looked blocked up. And now we're much more judicious about it because those people did so poorly. There's only a couple of areas in the coronary tree where people are much more likely to die if nothing is done. And for those people, we have a very frank discussion about that. The rest doesn't matter that much, believe it or not. So, again, you want someone who really understands the evidence and literature to date, who has a lot of experience in this space to help apply guidelines and recommendations to you in a very individualized fashion.
I believe it was Dr. Montgomery, who I was speaking to earlier this week during the conference, who was talking about stents, and he was talking about how when the more clogged arteries were more stable, and it was actually the arteries with less plaque in it, but that were more volatile. So that when you went and you put a stent into that more stable artery, even though it was more blocked, it actually could become problematic, putting pressure, causing potentially other issues. Versus if you put the stent in an artery that had less plaque in it. What are your thoughts on the?
Yeah, I'm not sure that's an exact accurate way. You may be saying it a little bit
Oh, I'm
different.
not.
But yeah,
I'm not a
yeah.
doctor, so
No,
yeah.
yeah, no worries. So if you look at the CT angiography data that we have, which gives us not just the lumen, which is what an angiogram, a traditional angiogram does, but the whole artery, we know a lot more about plaque morphology and composition than we ever have. And it turns out that the calcific plaque, the bright plaque that we see, is actually much more stable. In fact, people are often horrified to learn that when they go on a statin, their calcium score goes up, which is actually not a bad thing at all. It means that the plaque is stable. It also means it's probably permanent. So the sludge is sort of, like a lead pipe, it's there. And so the non-calcified plaque we know are much more likely to rupture and cause heart attacks. So in some ways, statins have a stabilizing effect on plaque.
Okay, and then, but with regard to the stent and placing the stent, are the more blocked arteries
Again,
becoming?
I would put a lot of caution on what you said there. That's why I didn't spend time answering it. What you're saying doesn't quite make sense to me. I mean, if somebody has a severe stenosis in a high prognostic territory, which is typically the left main or the proximal LAD, going after it makes sense. Whenever we intervene or instrument the coronary arteries, there's always risk for bad things to happen. So if you have a highly calcific blockage, not a degree of blockage, but one that is calcified. I'm not giving a degree because I'm not sure what it would be, but assuming that it was high degree, which would warrant a stent, you can sometimes shower out some of the plaque that goes down the coronary tree when we do that. Maybe that's what he was referring to, but sometimes the words get mixed up, and we have to be very, very precise in how we say these things so we don't confuse people.
So, how does a plant-based diet influence the management of cholesterol levels compared to traditional medications?
They're synergistic. They help to lower the LDL. In some cases, they help to improve some other risk factors. The one that doesn't change is lipoprotein A. So again, that's a 90% genetically determined.
And how does plant-based eating affect inflammation markers in the body, particularly related to heart disease?
Yeah, I covered this in our talk, but in general, when you eat and when you live and you put your body in an anti-inflammatory environment, not only does it tend to heal, but it tends to reduce inflammation.
And how do you reconcile the benefits of plant-based diets with the nutritional teachings in most medical schools?
Well, I would say what nutritional teaching in
Right.
most medical schools. We actually published a paper of 1,000. We surveyed 1,000 cardiologists, and 90% of us actually know nothing about nutrition. And so that's changing. And my good friend Steve DeVries runs the Gaples Institute. If you haven't heard of it, I encourage you all to check it out. There's some lovely nutrition lectures and information on there. But we're working to change that and get it into mainstream teaching. I, amongst several others, actually go around and give grand rounds for the doctors in lots of institutions. So it's getting better, but it's not there. But nutrition training is abysmal in the vast majority of places, including in my own training.
And to the extent that you're familiar with the nutritional training that is given in schools, in medical schools, what's your experience? Do they talk about plant-based versus eating animal products, or is it just
No,
general?
the vast majority of nutrition training is about calories. There might be a quick coverage about obesity. And then in some of the very hypercatabolic states like burn units or cystic fibrosis, they might talk about making sure people get adequate calories. They might talk about some of the vitamin deficiencies. But by and large, that was the extent of my training in nutrition.
Thank you. We've got one participant who has a question, so I'm gonna throw it out to Patrick M. Please, oops, let's see here. Oh, Patrick, if you can unmute yourself and state where you're from and ask your question.
Yes, hi. Thanks, Michael. Yeah, so Michael touched on it a lot. He's done a good job on this, but one of the great frustrations, I think, for me and a lot of other people when we're trying to understand a lot of this science that gives rise to the various positions that doctors take is the fact that there'll be a presentation that looks really good, and then in the very following presentation, somebody will come up and dispute one of the points that the prior speaker made. And, it makes it really difficult for the layperson to sort of catch on you. Just with the statins, doctor, is there, I found myself in a situation where in my early 40s, after having the marker of cholesterol be high from the time I started getting annual checkups in my 20s. By my early 40s, it reached a level where I was being advised to go on statins. So I took the step of I spent quite a bit of time looking into this myself. And the number of claims related to the trials, that would be the first thing. You're probably aware that there's an academic in the UK who for many years has been adamant that the selection process for the trials for statins were skewed to remove. They found some way of identifying the patients who would not react or had adverse reactions to statins, and the trials were salted by limiting the participation of those people. That's the first thing. The second thing is that there is a big gap between the level at which statins are shown to be effective, the level meaning the cholesterol measurement, and the level at which they've been adopted into practice at the standard of care. So in other words, the trials showed that if your cholesterol was above a certain level, and I forget the exact numbers, but it was extremely high, that these compounds, these medications had unambiguous strong benefits. But once you went below that threshold, that it was ambiguous, whether there were any benefits at all. And secondly, with the issue with the safety, it compounded the whole question about whether they should be used as standard of care at all. When they were adopted as standard of care, the threshold at which that was done was significantly lower than the threshold at which the statins were shown to be active. The underlying agenda, obviously, on the part of the drug companies was if you could do it that way, you would dramatically increase the number of people who would be using them. So just whatever thoughts you might have on that.
Yeah. So again, I would caution you, unless you are scientifically trained, it is indeed quite hard to interpret the literature, and everyone has their own take on things. And yes, I'll be the first to admit to you that randomized controlled trials and prospective trials have their limitations. But I would tell you that the most studied medication class on the planet is statins. And all of the professional society guidelines endorse them because they're very inexpensive. The side effect profile is actually quite minimal, but it's not zero, right? So every medicine you take is, probably a poison with a beneficial side effect. And the goal is to get to a place where you have more benefit and less poison. And so I think in general, many times what you're hearing from experts that are not sounding like me is a subset of the data. It's a subset of the knowledge as a whole, and I'm trying to hit it from a holistic perspective. And not everyone is able to do that or synthesize it. So I guess what I would tell you is I caution about people that don't have scientific backgrounds making inferences and conclusions. But I would also point you to that all of the major professional societies on the planet are volunteer, meaning people like me and others are unpaid to review the literature and write the guidelines based on the evidence. And you'll see that all of the evidence is in favor of using statins. That doesn't mean that's a forever, right? As better treatments or more knowledge comes out, those guidelines are reviewed and revised. So again, I think right now, state of the art, best bang for the buck appears to be statin. Now, again, there are certain populations that don't respond well to statins, and there are certain LDL levels where a statin may not be indicated. And there are ways to reclassify one's risk so a statin may not be needed. But if you've had a cardiovascular event, there's evidence to suggest that an aspirin a baby one, 81 milligrams in most cases, and a statin is quite beneficial. For the primary prevention cohort, these are people who have not had an event. It is a much more loaded topic, and there is a threshold where risk and benefit have to move in the favor of benefit for us to make a recommendation. And again, that is a very individualized thing that should be discussed with your physician.
Yeah, and yeah, I would love, and I'm not going to even try to represent what he said, but I'd love for you to check out our talk with T. Colin Campbell, who I'm sure you're familiar with him. He's a nutritional biochemist.
Definitely. I went to Cornell undergrad.
Yeah, right, exactly. And he talks essentially about statins, and he's not a big fan of them himself. But I'll let you. We'll take that. You can take that offline and check that out if you want to see what he has to say on that.
Yeah, no, I've seen a lot of the naysayers, and I guess I worry that there's unmitigated risk out there, right? So if it was easy as I need bypass surgery or an urgent stent, but wait, I'm going to eat some carrots right now and hope for the best and not have a problem, that would be amazing. But there's no evidence to support that. I wish there was.
Right. Well, just to clarify, the people who I'm referring to with regard to the stent are saying not they say in an acute situation, a stent makes sense. They're saying in a non-acute chronic condition that the stent doesn't seem to have.
So you're saying stents and statin. I just want to make
sure. I know. Now I'm talking about stents. I was talking about
statin. So for clarity, stents, as I already mentioned, do not save lives unless you're having an acute heart attack, or you have two areas in the coronary tree that are highly prognostic for bad outcomes without an intervention. The rest of the coronary tree, you could have very, very bad disease, and it may not have any effect on your longevity or outcome other than maybe some chest pain.
Right. All right. Next question is going to Marta V. Please state where you're from and ask your question.
I'm from New York, and I have a question which is not truly health related. For somebody who is without any major health condition, with not taking any medicine, where would you actually start to go vegan, plant-based, raw diet, something like that? You have something base recommendation?
Yes, from birth. So you should go plant-based the moment you're born. And preferably before that.
Somebody who didn't born yesterday, so.
Right. So it's never too late if that's what you're asking. But the truth is there's evidence to suggest that even in utero, right, when before you're born, the foods your mother eats actually has an effect on not only your dietary preferences, but on outcomes. So I would say the sooner the better. And if you're not there, do it today. There's no reason to continue on the same path that we're on.
Thank you very much.
My pleasure.
Thank you for that question. And what role does the gut microbiota play in cardiovascular health, and how does the plant-based diet influence this?
Yeah, so the gut flora, the microbiota, is a new frontier that we're just barely starting to understand. But remember that when you eat, you're also feeding your gut microbiome, and having a healthy gut microbiome is highly associated with better cardiovascular outcomes. Most of this work was done by Stanley Hazen with the TMAO story, and really interesting data. But TMAO, which is produced when you are an omnivore or a carnivore, when you eat meat, is highly associated with adverse cardiovascular outcomes. And it turns out that if you are plant-based, you don't even have the gut flora to produce this. They actually, in the name of science, had a study published where they fed a vegan a steak and they did not produce TMAO, which is pretty amazing when you think about it.
And what would happen? I'm assuming that would change over time as that same person ate multiple steaks, for weeks.
It's a chronic thing, right? So, again, people are like, well, what if you eat meat once a year or something like that? And I say, well, first, why would you even bother? It's like, why would you smoke cigarettes once a year? But that said, it probably wouldn't harm you. I think if we go back in time to a couple hundred, years ago, when we were more hunter-gatherer types, we probably spent most of the time eating berries and fruits and tubers. And on the rare occasion we killed an animal with a rock, we ate that for a few days and then we moved on again. So I think, what we do now is we eat highly processed, highly adulterated, chemicalized foods, and it is just bad. And it's concentrated in our animal products, unfortunately.
And can you speak to the dangers of people confusing whole food plant-based diet with a plant-based diet and eating the processed version of plant food?
Yeah, so for those of you that haven't tasted a Beyond Burger or an Impossible Burger, I mean, they truly are decadent and delicious, and they're very high fat.